a multidisciplinary team that stretched from doctor through nurse practitioner, through nurse, social worker, community health worker, all of the people who were or could be involved with any one patient. And I hope some of that same kind of life-changing experience is what lies ahead of you. It was my first time for an immersion in a different kind of center that was, in effect, community-based rather than hospital or facility-based. It's important to understand the origins of the transfer of community health centers from South Africa to the United States. Community health centers here were born effectively out of the civil rights movement, which first in the summer of 1964 brought many of us to Mississippi and other parts of struggle in the South, together with War on Poverty, the Office of Economic Opportunity, a new funding agency that was flexible and creative and interested in finding new ways to deal with poverty, including the whole problem of the burden of disease and the lack of access to health care that characterized poverty in this country. We added some things that had been impossible in South Africa's apartheid climate. We added community participation, community control at every level. Community health centers, as some of you surely know, are not-for-profit corporations with a board that receives the grants from the federal government and the income from Medicare and Medicaid, other insurers, and on a sliding scale, patients themselves. And 51% of the members of that board need to be current clients of the health center. There is no other part of the United States healthcare system in which communities have that kind of a voice and that kind of a participant role. That is part of what lies ahead of you. As community health centers to become fully qualified, patient-centered medical homes with all of the specific requirements for access and quality and electronic health records and coordination and chronic care management that term implies. They'll be, in effect, providing a model for the private sector because no facilities are as well equipped already in their organization and delivery modes for becoming patient-centered medical homes. And what will also lie ahead of you is that leadership component, the chance for you not just to see individual patients, not just to learn about the communities from which they come and which the health center serves, but also to get a grasp of what leadership of the whole enterprise involves, because you'll be having the chance to study and learn with the chief executive officer, the clinical director, and the chairperson or other members of the controlling community board. That lies ahead. I hope it turns out to be a glorious and instructive experience for you, and indeed that has an impact for years to come. I'll stop with that great wish, and I look forward to the chance for us to talk again together as the series unfolds.
Very much, Jack. We have other slides to show us about Jack's experience, or should we go on to Dan?
Well, the one that I just put forward, I don't. This is actually Dr. Geiger and standing in the construction of one of the health clinics in Mississippi that I believe he helped.
It is. It is very much Dr. Geiger.
Sir, I think I'm standing next to John Hatch, the community organizer, and that's the kind of person that you're not going to meet in a teaching hospital that you will meet in a community health center and stand to learn an enormous amount from about the communities you're working in.
Thank you for that background, Dr. Geiger. And I have this love shot here of you smiling, one of your university headshots, as a matter of fact. So that is to close off your keynote. So,
okay, well,
Dr. Geiger.
Okay.
Well, we'll be back to Jack during the discussion part of this. I'm pleased to introduce now Dan Hawkins, who's been with the National Association of Community Health Centers for many years himself, with a part of health center in his early part of his career, and sharing with us some perspectives from the national point of view about community health centers and something about your experience that you expect to have this summer. So, Dan, take it away, please.
Thank you, Merle. Can everyone hear me well?
Yes.
Wonderful. That's great. Thank you, Dr. Cunningham and Dr. Geiger, Jack, to all of us, just for your lifetime's worth of work and commitment on behalf of, most importantly, the people and communities that so need health centers and benefit from their presence today. And to all the young members of the Primary Care Leadership Program, welcome. Something both in terms of an experience and in terms of a learning opportunity that I think you will find unique and very special, and hopefully will have a great impact on your future career choices and locations and practice choices as you move forward. Merle mentioned that I began my life actually as the head of a migrant health center serving migrant and seasonal farm workers in deep South Texas. You can tell that I am not a Texan. Got down there in the VISTA program in the late 60s and began operating or directing the health center in South Texas just about the same time as Jack was finishing up, having set the foundation for health centers nationally and stability of the health center in Mon Bayou, Mississippi, and was moving back to New York at about the same time. I spent about 10 years down there, and my experience really pretty much set the path for my life. I came to Washington in the late 70s, worked in the Department of Health and Human Services during the Carter administration in the Secretary's office. Since 1981, have been with NAC, the national organization that represents all health centers. Jack has given you a great background on centers, their sort of founding, their founding purpose, and historic mission. What makes them unique? All healthcare providers in the country. He talked about a couple of those things, and I'm going to reinforce them. I want to quickly, though, answer a couple of questions that were provided by folks. We asked about whether the patient-centered medical home model is being used at health centers. In fact, about a quarter of all health centers have already either applied for or been certified by the National Center for our Committee for Quality Assurance, NCQA, as a primary care medical home. Most of them at the level 3 level, which is significantly advanced. And the goal for both my organization, NAC, and for the federal agency that administers the health centers programs, it's called the Health Resources and Services Administration, is every CHC, every health center in the country, will be certified as a primary care medical home by 2015. On a note, in fact, that we at NAC have created a primary care medical home institute headed by Dr. David Stevens, a former HRSA clinical expert who is with us now, and his goal is to oversee the movement of health centers to PCMH status. I think that's very important. I want to give you 3, 4, or 5 key points to remember about the experience you're about to undergo and what you're about to join. Jack mentioned some of these things. I want to kind of drive them home. When people ask me what a health center is, I speak in terms of their key features or attributes. The first is that health centers locate where no other providers, or very few, will locate and set up practice. And they care for those who providers have shunned or disregarded. They really care for what I call the forgotten and left behind in our communities and our societies. Because of that, health center patients are very difficult and sometimes frustrating to care for. because they face monumental obstacles in their daily lives. And they have been cast aside by the rest of the healthcare system, other than occasional use of the hospital emergency room or what have you. There's very little opportunity for folks, whether they're uninsured or even if they have coverage like Medicaid, to care anywhere else. And in fact, as Jack would tell you, the beginnings of health centers not only emanate from the experience that Jack had in South Africa, but from the experience of early Head Start programs in Mississippi and Alabama, whose children needed health care, but who could find no other local providers willing to care for those children. And it was then that the War on Poverty officials of the Johnson administration decided, if we're going to get care people, we have to develop a whole new system, and that's what health centers represent. Number three, health centers are the only providers who will care continuously for a person throughout changes in their income, their job status, their health insurance coverage, their health conditions, or their family status. Somebody asked about how do health centers compare to free clinics. Free clinics are wonderful and vitally important. You have the Vest Free Clinic out by Los Angeles. You have a free clinic in Phoenix and many other communities. We have one across the river from here in Arlington, Virginia, that every one of them is a vitally important provider of care. One big thing, when a person who is a patient at a free clinic gains insurance coverage, they are congratulated, celebrated, paid over, and then told, we can no longer care for you here because you have insurance. We need to keep that space open for an uninsured patient. At health centers, that doesn't happen. If you go from insured to uninsured to Medicaid covered back to uninsured, you will be cared for through all of those changes and through changes in your life and your circumstances and your health status. That's vitally important. The only providers who offer continuous care individuals throughout all their life cycles from birth to death. They are also the only providers, as Jack noted, who are uniquely governed by the very people they serve. The only corner of our healthcare system in which the people served have say over how they are cared for. We have patient democracies. Does it work perfectly in every instance? No, not necessarily. But when it does, it fulfills a vital purpose. That is to ensure that each health center is responsive to the needs of the people and community it serves. And the proof is in the pudding. You can go, many of you are in Los Angeles and Jackson and Nashville. There are other health centers in your communities. You should visit those other health centers, and I guarantee you, you will see a very different type of health center when you visit those other health centers, because they represent and they're responsive to the communities they serve. And finally, because of all of this, I tell you that health centers are more a calling than a career. As I said, that my center ran 40 years ago seeking physicians to apply and work at the health center, and we noted it's the hardest job you'll ever love. I think the point is, maybe go home tired as hell at the end of a workday, but trust me, you will sleep well at night and awake, refreshed and renewed and determined to do more the next day. That's what health centers are about. Changing the way care is organized and delivered, and changing the health status of people who otherwise would have few or no other options in life. That's it.
Thank you very much, Dan, for your brief and eloquent introduction. And I'm sure we'll have a healthy conversation here after the panel is finished. So next, I'd like to ask Brian Presswich to say a few words. Brian is with the Department of Family Medicine at UCS in Los Angeles and has been very active with working with medical students in community settings, and will be precepting some of the students on the call this summer. So Brian, it's all yours.
Hello, it's nice to be talking to you. You able to hear me okay? I hope.
Are.
Good. Well, my name is Brian Presswich. I'm at the Kickoff School of Medicine at USC in Los Angeles, and I'm a family doc in practice for about 25 years. I work in the safety net, and I'm a teacher, clinician, not primarily a researcher, but I'm very interested in healthcare redesign and redesigning the way we deliver care in this country so that everyone has good access to high-quality care. That's the perspective that I'm bringing to the conversation. I just had a couple quick things to mention by way of provide more context to the conversation. There is, in the country right now, thanks to the Obama administration and Congress passing two new laws, the Recovery Act and the Affordable Care Act, the government, the U.S. government has, which is the largest payer for health care, has it very clear that the unacceptable nonsense that's been going on in this country since post-World War II of delivering, frankly, very poor quality care to our citizens. We rank, 30 to 40th in the world on most healthcare indicators. This is no longer considered acceptable. We're being asked as physician leaders to lead a change in this country to deliver what we would call valuable health care, and that we find as high-quality health care at less cost. And government has really defined something called the triple aim that you read about later, but the triple aim that we are all shooting for here is better care, better patient outcomes at less cost or stabilized health care costs. And the good news is that the infrastructure, the payers in this country are entitled to pay for that rather than for commodities for high volume and that kind of thing that's been going on and undermining the quality of care that we're able to provide. The news is that in the last decade, there's been enough evidence in the peer review to tell us how to deliver high-quality care. And it is a primary care-based model. And Dr. Barbara Starfield, who is professor of family medicine and public health professor at Johns Hopkins University, who unfortunately passed away last year, did some really elegant research around the world. And she basically articulated something that we call the 4 pillars of primary care. And I want you to go ahead and when you go to your site, I want you asking yourself and talking to your preceptors about, are we providing the 4 pillars? If these 4 pillars, if present, have been known in small towns, in states, and in countries to provide the highest quality care at the lowest cost. The pillars are, number 1, a personal relationship with a physician over time. And the interesting question that we can talk about this summer is, how do you actually make that happen in a system? How do patients know who their doctor is? How do they have access to their personal physician? The only thing I would add is now we understand it's not just about the physician, it's about what we call care team. So it's a personal relationship with a physician-led care team over time. The second pillar is immediate access to the right care at the right time at the right place. The third pillar is that care is comprehensive. In the FQHCs, this is accomplished most easily by staffing with family medicine physicians like myself who have a very broad scope of practice, take care of the pregnant woman, the young child, the elderly person. Otherwise, what is that we use a combination of primary care docs, pediatricians, internal medicine doctors, OBGYNs, and some family doctors. Either way, the point is the care must be comprehensive. And the last pillar of the 4 is there is well coordinated. So when you're in the community clinics, you want to ask yourself, is a relationship over time? Are there care teams rather than just individual doctors working more in a vacuum? Number 2, immediate access. Number 8, care comprehensive. Are they having to be sent off to multiple places to get the care they really need? 4 is care coordinated. If any of those pillars we accomplish the triple, and your job as young scholars is to try to understand the system well enough so that you can begin to critique it and finally help us to improve it. And that's our challenge to you, and we hope to support you in your efforts. The last comment that I'll make is we make available to you a very interesting article that came from something called the National Demonstration Project. 3 highly sold practices across the country attempt to become medical homes that could provide true value, that could accomplish the triple aim. Unfortunately, only 3 of the 33 practices were successful in accomplishing the triple aim over 2 years. It turned out that the 3 that were successful had something called adaptive care teams. And I want you to think about that this summer. Think about your role in leading and working with care teams, not function individual doctor. And the article that we'll make available to you is called Relationship-Based Primary Care. And I just want you to see that article and think deeply about the implications for how you interact with your colleagues this summer as you're part of the care team working in the FQHC. I hope it's were helpful in encouraging you and getting you really excited about your experience. I'm looking forward to participating and working with all of you in some capacity or another, and I hope you have a very good experience this summer.
Thank you, and we'll look forward to more comments from you during the question and answer part of this. Panelist, Shireen Mark, currently an internal medicine resident, PGY2 in New York and Manhattan, with a clinic in Queens. And Shireen is a former alum, a scholar from the program. She is now up on video. We can see her face. So, Shireen, delighted to have you with us. Take it away.
Thank you so much for a discussion of myself. I am a PGY2 and still consider myself a scholar, and I'm benefiting from the work of Dr. Cunningham, Crutchwitz, and Dr. Geiger, as much as two fellow scholars are. You guys have been afforded a wonderful opportunity to work in community health centers, which is not typical outpatient setting that you'll get to experience in your residency training. I've been fortunate enough to work at a community health center called Community Healthcare Network in Long Island City, Queens, serving mostly African American, Hispanic, as well as Bengali population of patients in the heart of Queens. And I would like to echo some of the words that I believe Dr. Hawkins had mentioned in terms of it being a very fulfilling job. Working in that community center has been a very, very fulfilling job. It is stressful and tiring, but the outcomes and the patient satisfaction is immense. There's a team of 12 students ranging from PGY1 to PGY3 that work on, a health team in for our patients. I have a panel of patients that I get to see approximately every 6 weeks at an outpatient clinic. But during the time when I'm not there, I have 3 other colleagues that will step in for me and care for my patients, so they get to know them as well as I do, and I communicate with them the needs that my patient has and things that I'd like them to achieve during that visit that I'm unable to attend to them and their personal needs. I've been very successful in establishing continuity, I think, in terms of having a partnership with your patient. Since as residents, we will not be in the outpatient setting for a term of time. Only 2 weeks at a time is, I think, the most that many programs are adapting to. You definitely need to learn to work with a health team to coordinate care for your patients, because they will need more frequent visits than you can give them in every 6 weeks. And it's been very successful working the type of health team with my colleagues and caring for my patients, and their feedback has been very beneficial. It's also difficult to coordinate some of their specialty cases. Now you're isolated in a community and you need outpatients to other clinicians to care for them for additional needs that you might be able to provide. And communication is definitely a key in working with these specialists so that you're on the same page and making sure your patient gets the information they need. The neat thing about working the community health network is that I would say 75% of my patients do not speak English, and I use a translator service to speak with my patients. I recognize that there are definitely barriers in using a translation service, so we do, and we have gotten a group of Bengali healthcare workers to come in and teach us more about the culture, teach us more about the food that our patients are eating, so that we have a diet-based patient tray. We can discuss with them in terms of diet what they're actually eating, and tell them what to reduce, certain things that they're taking in their meal that they don't potentially think to high cost by having these healthcare workers come in and educate us about what the patients are actually eating. What they eat do not necessarily apply to the American diet that we are taught to count for our patients. So this is a unique experience for you guys that you not get once you go to your residency training to work in a community health care center with that is very is a privilege to work with these individuals. It's difficult to work with these individuals because of their needs, because of the staff they have, because of the education, because of the poverty and access that they have to health care. But it's very rewarding when you're able to have success with working with these populations. Congratulations and good luck with your future endeavors.
Thank you, Shireen. I'll make a few comments, and then we'll take some of the questions that people sent in and have active dialogue with our panel. I feel fortunate to be able to join this call. I'm actually one of the medical students to actually do rotations in a community health center setting in the 1970s in Western New York, and finally I was able to take a year off from medical school and actually study community health centers around the country at that time, and that to my joining the social medicine training program at Montefiore, where I was actually the first family medicine resident to be fully trained in a community health center setting. That first group of graduates from the 70s, from the social medicine program, many of us have gone on to do many different things in our careers, but very much like Jack spoke about being substantially affected in a life-changing manner with early exposure as a student, I can certainly share that experience as I'm still working at this. I recently retired after being chief medical officer in a large community center network in Brooklyn, affiliated with teaching hospitals, and been involved with student projects very much like you all are involved with this summer for many years, and I'm assuring you that you will have a very significant experience, especially for those of you that have the opportunity to be together with students from different disciplines. Medical, nursing, and PA students together is obviously the most effective way of learning, because that, in fact, is the model of care that most of us are using in the community health center world. So, turn to questions and a dialogue with the panel and the students. In looking at the questions that you all sent in, that Melinda consolidated for us, several of them related to different variations of the topic of systems of care and how health centers collaborate with other parts of the system. Obviously, following the Starrett pillars that Brian so eloquently reviewed, the community health center is the primary care home and the initial access point. Of course, there are other parts of the system that are absolutely critical, including the specialists that we occasionally need from time to time, as well, of course, as emergency departments, inpatient services. So some of your questions related to how health centers connect with other parts of the system, with specialty people, with other hospitals. And I'd like to ask Jack to start off with a comment about the systems of care, both the medical and the non-medical part, and then hear some comments from Dan and about that from your various perspectives. So, Jack, you comment on the systems of care and the critical role of the health center and how it connects with the other parts of the system.
Well, I think the key words is complex. Have already been mentioned a couple times, and they are medical home. And the whole point that Dan was making about the continuity of care, despite the changes in circumstances, insurance status, health status, income, residence, and the like that occur in any population's lifeline. There will be some community health centers are closely connected in one form or another with teaching hospitals. Others have reached out to establish those connections. They are experience for the teaching hospital because they're not that familiar with independently operating units that are community-based. But one of the things that community health centers are very good at. Making sure that when a patient is referred to and sees either a specialist or has an episode of hospitalization, that all of that information comes back to the community health center and can be coordinated with ongoing care. There are some health centers in which staff physicians, in fact, make hospital rounds, have hospital privileges, but the emphasis in most medical care is, in fact, on ambulatory care. What we look to in the day when all health records are electronic is a way for this system to be even more fully integrated. I'll refer to a study I saw recently of one private sector, good internal medicine practitioner in New York City. So they had the bright idea of tracking of his specialty referrals for his patients. He was, in one way or another, through his patients, in contact with 197 other physicians. Coordinating that, keeping track of that is impossible. A community health center is one of the best ways to do that.
Dan, your perspective on the systems of care and how the center connects in the challenges?
Can you hear? I had muted myself. Well, of course, going back to the earliest days, the greatest challenge, and it's been stated by health center clinicians and after study over the past 45 years, one of the greatest challenges they face is in securing specialty care and some more complex diagnostic services and even inpatient care, especially for their uninsured clients, but increasingly even for Medicaid and now, in recent years, even Medicare clients. And it's not exclusive to health centers. This is true for many, many other, even primary care providers who struggle to get the care for their patients, the specialty care that they need, because it is so difficult for specialty care physicians to accept a Medicare or Medicaid payment or to offer services at a discounted rate or pro bono. There are, I know, many health centers that work very assiduously with the local medical community and even have their clinicians provide some after-hours care and other kinds of care as part of the local medical community in return for the specialty care physicians providing a limited amount of pro bono care for patients referred from the health center. This is something that every health center has to work on. Some local medical communities are more socially conscious and more accepting and willing to work with health centers than others are. It's always difficult, but until we get to the day, and hopefully that day is at least to about the 2/3 level, only about a year and a half away, when there are fewer uninsured people, and therefore people do have a payer, and it's a little bit less strenuous and difficult to secure care for health center patients. There's going to be a problem, and it's not something that lends itself to a solution. Health center funding today is pretty big, $2.2 billion, but when you max it out, it works to a little over $600 per person served per year, and at that level, you just have enough to operate the primary care component of the health center. You can't afford to use health center's budgeted funds or the grant funds to pay for specialty care. The purpose of health, as Jack mentioned, is primary care, the entry point into the healthcare system, and you just have to be what I call social entrepreneurs, creative and collaborative, working with the local medical community to try to find solutions to these problems.
Dan, Brian, would you comment on this from your perspective, how the systems of care work?
Yeah, I would start off by with Dan's comment. I think let's all again context, it's quite remarkable. In the wealthiest country in the world, we're in 30th to 40th. We're basically providing bad medicine to our country. And in Dan's point, it makes clear why. If we have to rely upon doctors to do pro bono work to care for our people and our communities, we've obviously done something wrong. And Dan's alluding to the fact that, you know, as I had mentioned, under the Obama administration in Congress, we now are moving toward a more coherent system. In 2014, the health exchanges will be opening up unless the Supreme Court disrupts that process. And that means that about 33 million uninsured people will have a payer, as Dan mentioned. And this is an opportunity for us to do a better job of establishing linkage across the system. But remember that there are still going to be another 20 million people at least in the country who are still relying upon you know what Dan's describing, which is a completely unacceptable way for physicians who are supposed to be leaders and of the wealth of the health of the community, for physicians to in any way condone pro bono system. I think is that we think about that pretty critically. But what I would ask you to do is think about this. Think of a bullseye. In the center is the patient-centered medical home. Now, within outside of the patient-centered medical home is what's called a patient-centered medical neighborhood, which is mostly what we're talking about now. Those are the non-primary care-based who help us take care of patients. It's hospitals and it's imaging centers and it's CIS and they're in the medical neighborhood. And then those are within the larger circle, what I like to call a health-enhancing community. And since we're talking about what happened in South Africa with community or in primary care, we're really talking about a model that begins in a community that's capable of sustaining healthy living. And that's the context that we're thinking about when we think of a system. But if we focus on medical home, what I'd like you to think about is ultimately this is about linkage. And what I mean is efficient linkage to the services they need. You're always better off providing, again, remember one of the pillars was comprehensive care. So you provide everything you can in the medical home. It's possible, but when you cannot provide a service, you need to have very efficient linkage to that service. Remember this principle. Linkage, and need linkage, there's a possibility of what I call leakage, meaning that you refer to a neurosurgeon and they never get there. And the leakage of value, it means that money is wasted, and more importantly, a patient's health is wasted. So remember that you want to have as few linkages as necessary, because every time you establish linkage, there's an opportunity for leakage and for patients not getting the care they need in a timely fashion. Now, how do you establish linkage? You've got to have someone in your practice who is the point person to do care coordination. And the FQHCs all do this, and they really are a good example, as Jack mentioned, I think, they must really focus on care coordination. Remember, that's another one of the 4 pillars. But you have to identify a person in the practice on the care team who becomes an expert, who develops personal relationships with every member of the medical neighborhood. The thing I would say to you is, because there's someone in the office doing that, there's no replacement for MDs who are leaders establishing personal relationships with those colleagues, those organizations who help care for our patients. And that does involve, as was mentioned by Jack, getting out in the community and meeting people and developing personal relationships with them. There is no substitute for it. You can't do it electronically only. You can do it just by phone. And that's what you as a medical leader will have to do for the foreseeable future. When you go into practice, you will have to go out into the community and establish those linkages yourself. Have your team help you sustain them. There's a doctor, a pediatrician named Christopher Forrest, who wrote an article that I can make available to you called Specialist Typology. And what's nice about that is he describes, the concept here is that for me to work with a specialist, I have to understand, and the specialists have to understand what their role is for a given consultation. So remember that part of being a seamless system of care is, does the specialist understand what I'm asking for? Am I just asking for a procedure like an endoscopy, or asking them to take over the care of a very complex patient with cancer? There's a big difference. And in talking to each other and communicating to each other, we have to clarify the role for every single case. And remember, we need a health information system so that we can communicate. In this country now, practice physicians, and you'll see this when you get out into the clinics, do not have enough information to care for the patients well. We're not able to share information seamlessly. And part of establishing the system is investing in good informatic infrastructures that allow us to share information well. Those are my primary comments, and I think it's just a great question that you guys are asking. I'm glad you brought it up.
Two comments I'd like to make on that before moving on to another question category. First one is it's not just physician leaders in the communities at the centers that are very effective in making the connections with all the other organizations. We have a substantial number around the country within our health centers of PAs and nurse practitioners who have become leaders in their systems, are very effective in being leaders, working with other community groups in the various parts of the country, both urban and rural. Clearly, the physician leaders have the principal role in working with the medical community, but that, of course, is only one part of the larger neighborhood that Brian was talking about. So there's a substantial leadership role for PA leaders and nurse practitioner leaders, as well as physician leaders in the community health world. The other Go ahead.
I just wanted to add one comment to that. You have arrived at your community health center after you've met everybody and know which way is north and can find your way around. One of the most useful ways you can begin is to find a community health worker or one of their other outworkers or one of the visiting nurses and have them take you around the community that health center serves. So you have some grasp right from the beginning of where it is and what's there.
Excellent suggestion. The other comment I wanted to make and follow up to Brian's comments were in terms of the electronic health world. All of you are going to be working with health centers that are automated. 80 to 90% of all the health centers in the country either are fully installed or will be fully installed within the next year, according to a survey that we completed at GW last year, far in advance of the private medical sector. So you will all have the opportunity of being familiar with the challenges and the issues of electronic health records, not just internally within the health center itself, but as Ryan mentioned, challenges of having information flow about your patients from one part of the system to the other. Everyone isn't fully interoperable is the term that's being used in terms of their electronic health records, but you will certainly become more experienced in the area with health centers you're with this summer. The next category of question that I thought would be useful to deal with the panel is a set of questions that relate to prevention, preventive medicine, lifestyle concerns, and how community health centers have positioned themselves over the years to work effectively with prevention strategies and other perhaps non-medical interventions to help improve the overall health status of people that they serve and folks in their community. Could you start off on that one, since you had some very clever and innovative ways in the early years of helping deal with nutrition and other community problems?
Oh, that's what Merle is referring to. Is it's become an iconic story, but a true story. And this was in an earlier time when there weren't the other kinds of support mechanisms around that exist now. And we had a population that was deeply malnourished, employed, displaced by the mechanization of cotton agriculture, didn't have money, couldn't afford food stamps, and we saw over and over again children who were nourished and infected from drinking water from the drainage ditch. And one of the things we finally decided to do about that was to have our physicians write prescriptions for food, and made an arrangement under which all of the children in a family in that circumstance could so much meat, so much fruit, so much vegetables for a couple of weeks at least during the acute phase of illness and malnutrition, go to their local grocery store, fill those prescriptions, and there was an arrangement under which the grocery store sent the bill to the health center, which paid for it of the pharmacy budget. And the state of Mississippi screamed this was Russian socialism, and the federal government got upset and came down and yelled at me that the pharmacy at a health center was for drugs for the treatment of disease, and I responded that the last time I looked in a book, the most specific therapy for malnutrition was food, and they went away because they couldn't think of anything to say to that. It's better now, and there are other resources around. What we need to be doing now, and what health centers are increasingly trying to do, and what you may indeed find a way to play a role in, is to establish collaborative relationships with other agencies, public health agencies, housing agencies, community groups, food stores, banks, to see if that same end can be accomplished. A lot of what's wrong with our patients is what's happening in the community, the social determinants of health. Community health centers can't do that by themselves, but they can do what we used to do in Mississippi collaboratively now with other agencies.
All right, Jack. Dan, can you comment on some of the other strategies that are out there now in terms of effective programs, such as the ones that have evolved with the Health Disparities Collaboratives over the last decade or so with health centers?
Oh, yeah, sure, Merle. I mentioned at the beginning that our own Primary Care Medical Home Institute, PCMH Institute at NAC, is headed by David Stevens. Stevens, together with, in collaboration with Dr. Don Berwick, the immediately former CMS administrator during the Obama administration here, actually collaborated back in the mid-1990s when Dr. Berwick headed the Institute for Healthcare Improvement, IHI, to create a care management kind of revolution at health centers, following the Ed Wagner chronic care model, but using a rapid study and learning process to establish what they called Health Disparities Collaboratives, proactive health care focused rather than illness or sickness focused care for patients of health centers. And virtually every health center has gone through at least one Health Disparities Collaborative for at least one condition: hypertension, diabetes, asthma, cancer prevention. Whoa. Really? At any rate, for all of these different conditions, and even for prevention, health centers were trained on how to turn the system of care from sickness care, being at the bottom and receiving end of that slurry of sickness that comes in every day, to care management and health care, which I think did wonders also for medical staff morale. It certainly did for the patients as well, as they engaged in planned visits, group visits, in which the providers literally became coaches and cheerleaders, drawing up the plays that the individual patients needed to use to improve and then maintain and control their health, and then cheering the patients down the field as their hemoglobin A1C levels or their blood pressure levels dropped. And it was almost like AA for chronically ill people, where they come in and talk about how their HbA1c level was, the latest reading they had, and they would be cheered and encouraged and helped and counseled to improve their health, to take control of their health, to recognize that it was their health, not somebody else's, and that they could manage it and do a better job. These Health Disparities Collaboratives have then spawned and contributed to and led to further improvements at health centers. Many of them went to open access scheduling, same-day appointment capability. There were so many other changes in the improvement of the care process. And I'm sorry for the background noise. I don't know who is engaging in that, but forgive them. At any rate, All this has led to a much better care management system at health centers. And I don't believe we're at the end of that. I believe we're still at the beginning. I believe whether it's primary care medical home or care coordination, care management, more is yet to come. And so you and the centers you'll be practicing at will hopefully be part of moving that revolution forward. Stop there.
Yeah, thank you. And unfortunately, we're out of time. I was hoping for Brian and Shireen to comment on this. Also, obviously, we have many further questions that came out of the group, and it would be my expectation that we could actually fashion those into a series of weekly, bi-weekly type webinars that we could arrange that you all can participate in from your various sites over the next 4, 5, or 6 weeks. Again, you have great questions that have come up. You really have a chance to deal with them locally at your sites, but there's always a terrific advantage value of sharing from site to site, and hopefully with the folks at the foundation will be able to accomplish that. I wanted to thank once again Jack Geiger for being kind enough to give us his time, and Dan Hawkins, Brian Presswich, and Shireen Mark for being part of our panel today. And I guess I'll turn it back to Melinda or Esther for any concluding comments from the foundation.
Merle, very much, Dr. Cunningham, for being here and being our excellent moderator today. I really appreciate your service. And again, to everybody here who can hear me and or see me, I want to thank you for joining us. And I also want to say any apologies for our learning curve here on this, but I think it has been an information-rich experience, and I agree with Dr. Cunningham. I hope that we can make this even more frequent than we already plan to do, because there is so much to be said on this very important topic. So thank you very much to all of our attendees and presenters and panelists. Thank you very much, and we'll end the session.
So everyone just clicks off, and we'll reconvene. Right. Goodbye.
Bye. Thank you.
Bye. Yeah. Thank you.
Thank you.
Thank you. Bye-bye.